lots of interest in today's topic. I'm going to pass it over to my colleague, Niti, because here in Toronto, it is 8 o'clock in the morning, and that's the time when we get started. So
good morning, good afternoon, good evening, everyone. Welcome to webinar number 45. For our webinar today, we have Dr. Emily Gallagher from Seattle, Washington, and Dr. Emily Nyamu from Kenya take us through their learnings from PACT, Partners in African Cleft Teams, which is an education. Sorry, I'm getting a request for recording. So the PACT is an education model for comprehensive cleft teams based in Sub-Saharan Africa. So we will be having simultaneous interpretation in Spanish for the entire duration of this webinar. Ben and Eva are our interpreters for today. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please select Spanish. If you would like to continue in English, select English. As promised, we've launched the COCP Circle platform exactly a week ago to this day, and we already have 175 members actively networking on Circle. So if you haven't logged in yet, today is the perfect day to log in and join in on the conversation. Also, don't forget to check out our revamped COCP website. It's gotten a whole new look. And stay tuned. Towards the end of the session, we'll be sharing our top 5 tips for effectively engaging with your cleft care colleagues on Circle. What's our agenda for today? We have already shared our COCP update. We will now move into the presentations from our 2 panelists for the next 25 minutes. This will then be followed by questions and discussion for the remaining half hour.
Great.
We thank our 10 international charity organizations whose coming together and collaboration has made the COCP and all of its initiatives possible. Over to you, Hugh.
all right, we had a bit of a spotlighting issue there, but we're working on the tech this morning. So Emily Gallagher, we were working on your tech too. This is all coming together. We're delighted you're here. It has been lovely to see some of you, many of you, log on to Circle for the first time. If you don't know what that is, stick around to the very end. We'll do a brief update and also how you can make the most of your experience on Circle if you're new. But again, I am delighted for this webinar. It's been a time in coming. Emily Gallagher and I sat next to each other in Edinburgh at the Cleft Congress, and that sort of started an interesting discussion, me catching up a little bit more about this program that has been going really rooted and initiated from Seattle Children's Hospital, and then growing in all sorts of really interesting ways, which you're going to hear all about. So, I mean, this is such a neat thing, I think, both to understand better how African cleft teams have been developing, but also what we can learn about that model for how North and South and East and West, how everyone can work together in seeing the development and the expansion of comprehensive cleft care, which of course is the animating vision of us on this call, which we're so delighted, whether it's morning, afternoon, or evening, that you've joined us. So since 2012, Partners in African Cleft Training has offered a 1-week training workshop for providers to promote sustainable multidisciplinary cleft care in Sub-Saharan Africa, but it's so much more than that. So we want to know a little bit more about what PACT has learned about promoting CCC, how the program's evolved, and also what elements could be provided, it could be adapted into your context. So without further ado, Dr. Gallagher and Dr. Nyamu, both go by Emily sometimes also, will start us through. Dr. Gallagher is a pediatrician in fellowship training in the Craniofacial Medicine department in Seattle Children's, as I mentioned, and Dr. Nyamu, who gave us the wonderful weather update this morning, is an oral and maxillofacial surgeon who completed a fellowship in clefts in craniofacial deformities surgery. She works as a maxillofacial surgeon in Nyeri County Referral Hospital in Nyeri, Kenya, and it sounds like a lovely place to visit, so I'm going to put that on my list, Dr. Emily. All right, now we've rehearsed this once. Let's see if it works. Dr. Emily Gallagher, would you please share your screen and we'll give you the floor.
All right, here I go.
And it's coming. I can see it.
It's coming. I'm doing my best.
Yeah,
Not the fastest.
We're a webinar 45, so we've experienced basically all kinds of different kind of Zoom hiccups and challenges. But then, of course, as soon as you've got everything figured out, Zoom will change some of their code, and then all of a sudden the defaults have changed. We are now seeing exactly what we wanted to see, which is your view, the actual non-presenter view. Dr. Emily, go ahead.
All right, great. Well, thank you so much for the invitation to speak this morning, this afternoon, this evening. Thank you all for being here and sharing this time with us. So what I hope to do today is to share with you the history of PACT. I want to go over the goals of PACT and share some examples of the PACT model. We're going to talk about why this model is unique and the impact that PACT has had in various ways. And then I'm going to turn it over to the other Dr. Emily to talk about her perspective on how PACT has helped shape her team. So first of all, I do need to acknowledge that I have only been part of PACT since 2019. I have benefited so much from all the work that's come before me, and it's humbling. I feel so honored to be able to participate in PACT, but I can't take any credit for setting up PACT. I'm merely the presenter here. So PACT really started in 2004 with some conversations that were initiated by Dr. Peter Doncourt, shown in the photo in the middle. Professor Doncourt is an oral maxillofacial surgeon from Kumasi, Ghana, and he started some conversations with Dr. Michael Cunningham, shown in the picture on the right, who is a pediatrician and medical director of the Craniofacial Center at Seattle Children's Hospital and at the University of Washington. And they started discussing how they could improve cleft care in Sub-Saharan Africa. Soon after that, Professor Doncourt was selected to be the visiting professor from the ACPA, the American Cleft Palate Craniofacial Association, and Seattle Children's became his sponsor. So these conversations had time to evolve. In addition to talking with Dr. Cunningham, these conversations also included Dr. Richard Hopper, shown in the photo with Professor Doncourt in the middle. Richard Hopper is a craniofacial plastic surgeon. And with financial support from Smile Train and Seattle Children's Hospital Foundation, they were able to begin a needs assessment in 2008 with the goals of answering these questions. How can we enhance cleft care in Sub-Saharan Africa? And what is needed for sustainable interdisciplinary cleft care? The learnings from this needs assessment were later used to create PACT. And at this point, they had partial funding as well from Transforming Faces. The needs assessment started as a 3-year project to establish specialized training centers in Sub-Saharan Africa to support sustainable interdisciplinary cleft team care. And this initiative included not only the providers from Seattle and from Kumasi, Ghana, but also Dr. Olasoji from Maiduguri, Nigeria, and Dr. Makonnen Ishete Abebe from Addis Ababa, Ethiopia. And what they did in 2011 was designated these specialized training centers for surgery in Ghana, for anesthesia in Nigeria, and for speech in Ethiopia. And these became resources that still exist today for providers in Sub-Saharan Africa. PACT later evolved to include these workshops, which we're going to spend time talking about today. These workshops have provided training for over 190 participants over the years. And in addition to the three countries I already mentioned, Ghana, Nigeria, and Ethiopia, PACT also includes host teams now from Liberia, Kenya, and Tanzania. So there's 6 different countries who come together in one location for these PACT workshops. Dr. Ann Hing, shown here, is the current PACT director, and I cannot tell you how important she is in the success of PACT. She is responsible for every detail of the workshop. She thinks through and considers every aspect of the curriculum, the logistics, and everything, and always has new ideas about how to do things in a more innovative way. And she partners with the PACT team leaders to make decisions about the curriculum and also the future direction of PACT. So her leadership has truly been crucial for the success of PACT. So through all these years and all these changes, the goals of PACT have remained consistent. The goals are still to promote sustainable interdisciplinary team care for children with clefts as guided by the African cleft providers. And this now includes an annual 1-week seminar, as well as a quarterly virtual seminar and an online classroom. And through all of these venues, the goal is really to model team care. We see patients together, we discuss patients together, we make decisions about treatment plans together. And while there are opportunities to have breakout sessions that are discipline specific, there's a lot of time where all the medical disciplines are in one room talking about the same issues. So there's this awareness among all the providers that it's really important to have a basic understanding of the perspectives of the other disciplines, as well as to be able to listen to each other in order to provide the best care for our patients. So I want to review now this example of a typical curriculum agenda for an annual 1-week workshop. So typically on a Monday when we start, we all come together and there's some lectures about things like an introduction to PACT, introduction to team care, the timeline of care for children with clefts. We might have some time on Monday morning to break into some discipline-specific groups to talk about patient care. But then after lunch in the afternoon, we come together in clinic. And in clinic, we see patients by disciplines. The patients who we're seeing were selected by the host team as patients who might be considered for surgery later in the week. And each discipline sees each child separately. But then we come together at the end of the day to discuss all of the patients who we've seen and talk about the plan for who might be a good candidate for surgery that week. I'll talk more about how we do this in a minute. Then on Tuesday, the surgeons and anesthesiologists will go to the operating theater where they'll operate all day. And at the same time, the people who don't work in operating rooms will gather together for more lectures, small group discussions, and other things like that, other opportunities for learning. In these sessions, we tend to cover things that may be more relevant to the non-surgical fields. We'll have more time to discuss nutrition, psychosocial issues, maybe complicated speech assessments and things like that. And we typically will focus on younger children and infants on the first day, and then on Thursday, when we come back together for this type of learning, we might focus on older children and adolescents. In the afternoons, we typically have time for discipline-specific care while the others are still in the operating theaters. And for example, the pediatricians would typically go round on patients in the hospital. The speech team would often see children who had been selected for speech assessments as a group or speech therapy as a group. And the orthodontists typically peel away and go to the dental clinic during this time. At the end of the day, everyone comes back together as a group, and we have time to discuss challenging patients who need input from the teams. We invite everyone who's coming to PACT to bring examples of challenging cases for these discussions, and these are a really fun part of the week. Wednesday and Thursday follow the format for Monday and Tuesday, but they start a little bit earlier so that there's time for post-op rounds, so all the patients who had surgery the previous day can be seen. And then on Friday, after post-op rounds, we might have time for discipline-specific patient care topics again, but then we come back together for group lectures and some wrap-up. And this day would typically include a discussion about the barriers of sustainable team care in Sub-Saharan Africa. We might discuss future direction for PACT, other topics like that. And then on Friday afternoon, it's time for most people to start the long journey back home. So I want to highlight this readiness for surgery checklist that we use. This is a form that follows each patient when they go through clinic. And you can see on this form, there's a section for each discipline to provide some input. If there are any concerns noted, we can write notes on here. Sometimes we see patients and their concerns about malnutrition or acute illness, or maybe a medical condition that hasn't been fully evaluated. We hear a murmur for the first time. We look at some blood work that we don't think is quite explained by the whole clinical picture yet. And so sometimes we recommend other treatment. But when we come together as a group at the end of the clinic, this form is what drives our discussion as a group. And there's not always agreement about what to do. In fact, sometimes there's sort of heated discussions about whether a patient would be safe to have surgery the next day. But we found that this form is incredibly useful in helping us shape our discussion, talk about each discipline's perspective, and learn from each other. In a prior survey of PACT participants, somebody wrote, the voices of all disciplines were respected and heard during the team review of surgical readiness. And I love this because I feel like it really highlights this very important part of the PACT workshop and the fact that, that all providers there have an equal voice. This is an example of some teaching going on in the operating theater. We often will use an endoscope so that someone who's not able to stand in the surgical field can still be nearby and be watching what's happening and listening to this discussion, so others can still be learning from the surgery that's happening, even if they're not scrubbed in. And then in addition to these annual week-long workshops that we have these virtual seminars that I mentioned. We hold these quarterly, and they last about 90 minutes. Usually these are led by PACT team members, and we rotate through all the different teams. And it's really up to the teams to decide what they want to present on. Sometimes there are lectures, sometimes there are panel discussions or discussions of challenging cases and how the team had managed those challenging cases. To give you another example, we recently had a talk by Dr. Ola Soji with the title, Dynamics of Effective Decision-Making in Interdisciplinary Cleft Team Meetings, Collaboration and Conflict Resolution. And his talk was really excellent and appreciated by so many people. With regards to the virtual classroom, this is something that we give access to for all PACT participants, and they can access it any time of the year. It holds a lot of resources that we think are helpful for people. There might be reference papers, video recordings of previous talks, sessions that were recorded separately about specific topics. And the PACT members can access this anytime. It's really a way to maintain their engagement throughout the year between these other events. So I wanted to talk a little bit about the impact that PACT has had. We asked questions about what has been the impact of the PACT program on your team's growth and patient care in a 2023 leadership survey. So this is a survey given to the PACT leaders. And you can see in the charts on the right that both the number of team members and the number of disciplines on the team has increased for most of the teams since PACT was started. And we're not saying that this is directly related to their participation in PACT, but I do think it reflects the work and the focus and the ability of the team leaders to be resourceful. And maybe some of that is coming from their participation with PACT and networking that happens at PACT. In addition, there were a number of comments on this survey and other surveys that I'd like to highlight that people cite as the impact of PACT on their own practice. People have noted improved surgical skills and knowledge, improved support of speech and nutrition, improved quality and scope of care, improved communication and synergy of care, improved safety, both surgical and non-surgical, and better collaboration between the African teams. There were a few other things that resulted from PACT that we might not have anticipated so directly that I wanted to mention here. One is the Nifty Cup. The Nifty Cup is a specialized cup feeder for feeding an infant who cannot feed directly at the breast. The mother can hand express breast milk directly into the cup, and then there's a small reservoir at the tip that can be used to feed the baby very gently and slowly. And this is used quite often by with infants who have clefts that involve the palate, or by premature infants who can't breastfeed for reasons related to prematurity. And the Nifty Cup resulted from PACT because Dr. Cunningham early on had a lot of discussions with PACT participants and team leaders about the difficulty accessing cleft-specific bottles in Sub-Saharan Africa. And he brought this idea of improving this cup back to Seattle, where he collaborated with a number of other people to develop this cup that is now manufactured by Laerdal and is more widely available. We bring Nifty Cups every time we come over for PACT workshops. Dr. Hopper was also involved in a number of things that were more related to surgical instruments. There was a lot of redundancy in the surgical instruments that were required for cleft palate repair, and they were able to simplify the instruments that were required down to 4 critical instruments. And those were the only instruments needed for cleft palate repair. And so Dr. Hopper worked on this with other PACT members. And now these 4 instruments are what we tend to bring over to PACT participants to make sure they have the tools they need for the palate repair. In addition, Dr. Hopper helped develop an oral retractor for cleft palate repair that has improved visualization of the surgical field and also improves the stability of the endotracheal tube, making the surgery safer for the infant. So we think the PACT learning model is unique for a number of reasons. For one thing, we are always modeling interdisciplinary care. We have all of these different disciplines listed here who are typically attending a PACT workshop, and all the team members are working very closely, showing each other how we think and what our perspective is about different situations. The focus of our learning is truly on team care and the impact that this has on patient outcomes. Another thing that's unique about PACT is that the participants are selected by the team leaders. The team leaders are the ones who know their teams best, and they're in the best position to choose both the individuals and the disciplines that they think would benefit from attending a PACT workshop. Also, it's quite common to have longitudinal learning, so many participants will come year after year, because what happens is their learning really grows and develops, and then we can see this evolution from being a trainee to being a trainer, which is very important, both helping to train others at PACT, but also train people in their home institutions. So we have learned so much from PACT over the years, and I'm just going to highlight a few things here. One, we know that listening is important. We're taught to listen to our patients, listen to our patients' families, but listening to each other on teams is also crucial. And listening to all of each other when we come to together as a group is one of the most important things with our learning at a PACT workshop. This shared teaching and learning benefits all participants. I always learn from some of the discussions between the surgeons about their approaches, even though I have no desire to go to the operating room. I'm not a surgeon. And most importantly, we know that the solutions must come from within the African continent. These are the people who know their practice best, and we want to provide the support for them to come together, but we really are relying on the African providers to come up for solutions for their own teams. And many friendships have also resulted from PACT participation over the years. So thank you so much. I'm now going to turn it over to the other Emily for her portion.
So thank you everyone, and hello wherever you are. It's my pleasure to take you through our journey as a Nyeri Cleft team. And we've been in existence for 11 years now, and it wasn't always easy. So I would like to share that journey and just to encourage all the clinicians who are out there that these nice organized teams that are working in synergy start from somewhere, and you can all start wherever you are with whatever you have. So the Nyeri County Referral Hospital had always done cleft work, but as an outreach center. I was posted there as a surgeon in 2009, together with a plastic surgeon. So before that, they used to be used as an outreach center, and doctors would come from all over the world, or even from Kenya itself, come perform cleft surgeries and then leave. And indeed, I did come in 2008 as a surgical registrar when I was studying my oral and maxillofacial surgery. And I even collected data for my master's thesis there. So in 2009, the two of us were posted, but we were just finding our footing, had to even start our own services, myself as a maxillofacial surgeon and Dr. Saidi as a plastic surgeon. So we didn't start the cleft service immediately. We just allowed them to continue as they were. So around 2012, 2013, we both did cleft specific training. Dr. Saidi had been in practice for a little longer than I had, and from his plastic surgery had been performing cleft surgeries before his posting, but I had come in straight from my master's program. This was my first posting as a surgeon. So what I did is I did a 1-year fellowship in India, which was sponsored by trustees of Future Faces. And one of my main mentors at the time was Tony Marcus. He still is, and we'll still catch up and ask how we are doing as a team. So during this training, I find for me, this training was pivotal in the sense that it was done in a center in India that was already a comprehensive cleft care center. So I trained my cleft surgeries in a center that was already having all these disciplines working in synergy. And so in my mind, this was what I wanted to come back and set up back home when I came back. Next slide. So those are my contemporaries in India. I did it at the Jubilee Mission Hospital, Thrissur, Kerala, under Professor Adenwala, who passed on a couple of years back. But the team still goes on, and this is a beautiful team. Let's go ahead. So when I came back, both myself and Dr. Saidi were very concerned with how cleft management was done at our hospital. And we really wanted to move it from the outreach type of service to a comprehensive cleft care center. So the first thing was to partner already with an organization that already lauded that type of model of taking care of cleft patients. And this for us was Smile Train. So we partnered with them, and in 2013, April, we actually did our first surgery. So from our STX records, that's the first surgery we did, and we said the team was born in April. So what did we have at the time? We had 2 surgeons, we had theater nurses, anesthetists, and ward nurses. Though the theater nurses, anesthetists, and ward nurses were not really trained for clefts. We just started and began the training after starting, because they were already handling surgery patients. This was just a cleft patient who was a child, and we were walking them through the cleft surgeries. So in a couple of months, we did start cleft-specific training for the nurses with Smile Train. So kindly. So this is one of our initial theater nurses at inception. Actually, this lady, it's very special because she had a child who had a cleft and had suffered through the system, having the child treated in outreaches, and had to travel so far from home to follow the surgeons wherever they were doing the surgeries. So we had sympathy from them. She's actually one of our head theater nurses and was quite pivotal in this training of nurses and ensuring that we set up a team in Nyeri. Next slide. So as I said, we started with the nurses training, and this was later, we included the BLS training and PALS training for all team members, not just the nurses. So they'd have the nurses cleft safety training for the pre and post-op period, but then we'd also have the BLS and PALS for all team members. The treatment offered was just surgery when we started. So we could do the primary cleft lip and palate repairs. We were doing a bit of alveolar bone grafts from the older patients that had been seen at the outreaches, and then the secondary repairs also of those older cases that had been seen. So the next hurdle was speech. We knew we needed speech therapy, but we didn't have a speech pathologist. Actually, in the country, I think there was only one lady in a Farof hospital in Nairobi at the capital. And we knew we needed one at our center. So in 2015, a training opportunity came up, and one of our OR nurses was very interested, and we sent her for that training. So that's how it started at Yekatit Hospital, and I believe Professor Mekonnen was part of this. These are the I would say they've been visionaries in Africa, knowing what can be done, and they start these centers, and for us, we managed to send who is interested to train. And this is how our speech therapy journey began. Next slide. So she did train in 2015, then went for advanced training in Kumasi, Ghana, and then went again for more training in 2017. So we had speech already done. And even as she was going for this training, she started speech therapy on our cleft palate patients, though we hadn't started uploading the cases on our system yet, but she was doing the speech therapy. So the next thing was cleft orthodontics. So in 2018, our pediatric dentist went for a pre-surgical orthodontics training. And then in 2019, this is where we were invited for our first PACT meeting as a team. So in Kenya at the time, I can say we were doing our surgeries and we had our speech already going on, speech therapy going on. So we were asked to send in 2 specialties, and I went myself with the speech assistant who had trained for the years through the Katit training and Kumasi training. Next slide. So this is us in Ethiopia at our first PACT meeting. Next slide, please. So what impact did this 2019 PACT meeting have? Actually, we were very encouraged by the teams we met at this first PACT training in Ethiopia. And we just loved how everyone seemed to work in synergy. Like there was such good communication between the departments from when the child came in, how they were handled, how the nutritionist would come in and give their concerns, how the speech therapist even saw the patient before the surgery and continued to see the patient. So we just loved to see how the Seattle team and how the bigger Ethiopian teams who were the hosts at the time worked, and all their departments working. And so we went back home. We were given some nifty cups and surgical instruments, and we resolved to continue adding, whatever bits of the multidisciplinary management we didn't have in our team. So the first thing that we could immediately was to include the nutritionist in the hospital. And she was very enthusiastic, had a bit of training in the cleft nutrition, and actually became so good that she became a trainer of trainers in the other African training of African nutritionists for cleft teams. And then we started to involve the dental team. We actually don't have an orthodontist in Nyeri, but we have a pediatric dentist and we have a dental surgeon who is very interested in orthodontics. And this started getting involved in training for cleft ortho. So the second person in the team managed to go for his pre-surgical orthodontics training, I think the next year. Next slide, please. So in 2020, the COVID pandemic hit, and we didn't do any cleft surgeries because here in Kenya, actually the hospital was just taking care of the COVID patients, and all these elective cases were pushed to the back burner, sort of the COVID pandemic. So we took time as a team to see how far we'd gone and to see what more could we do in this lull period, in this 1 year. So for a long time, we'd been pushing Smile Train to refurbish our theater and our ward. And because this year they were not going to send any funds for surgery, they actually said yes to that. So that's what we did in the 2020 period. Next slide. So that's Dr. Saidi, the plastic surgeon, at the groundbreaking where we broke down that wall and the ward refurbishing and theater began. Now, during this year, even as we were regrouping as a team, we realized that there's only so much you can do in terms of you have members managing the patients, the multidisciplinary team. But then the hospital must buy into the idea, and you have to convince them why they should put aside a theater or give in another staff to go and train or fund something. So we realized we needed to onboard the hospital administration, And actually in this year, we did form the cleft administration team, which included the cleft surgeons and then the hospital administration, especially the accountant, the nurse manager, and the medical superintendent, who is actually the head of the hospital here. Next slide. So in 2020, we applied for an orthodontics grant with Smile Train. And then in 2020, 2021, and 2022, we continued with the virtual PACT meetings because, again, because of the pandemic, there were travel restrictions, and this is how we could communicate. And we continued to be encouraged by all the team members. So 2023, we had a PACT meeting in Kumasi, Ghana, and this time we sent in a member from surgery, from speech, and nutrition. So this is one of the group sessions where all the team members are actually together and we discuss cases. Next slide. So what happened when we came back from the 2023 PACT meeting? Again, we were really encouraged as a team to push on. So when we came back, we started outreaches as a team to 2 other hospitals in the northern region, very remote northern region of Kenya, where we do see cleft patients and go back at least twice a year. But we are doing this with the aim of capacity building in those hospitals. So right now, we've trained their anesthesia team and we feel they're comfortable. And we are actually looking to see if we can train their general surgeon or any other surgeon who is around, who can now begin to learn how to do clefts. Then nutrition itself started uploading their cases on the Smile Train program. We formed a cleft team with all departments involved to ease communication between team members. And actually, we managed to have synergy, like good coordination, like from when a cleft patient comes to casualty, how are they handled, who takes them, which departments are they taken to, when do they get their surgery, who cancels them. So all these departments were involved, but we picked the dental department to be lead in this. And actually our nurse coordinator, who's actually the glue of this team, sits in the dental clinic, and she manages to somehow communicate, send the communication between the departments, but also handle the patients very well, even the social aspects of, say, the patient is supposed to come for an appointment, but they didn't have transport to come to the hospital, she will organize for that. Or they need a test done. Sometimes we have patients with cardiac issues. We don't have a pediatric cardiologist, but there's a visiting one who comes every month. She will organize and make sure that the visiting pediatric cardiologist has seen the patient and all that all the tests are done. So we somehow started managing to make the communication easier. Next slide. Usually the surgeons in our team are the leads, so they will see the patient and then send them to the appropriate departments as they come in for review. But I want to say that very strong nurse coordinator, and we really love her, is the person who actually makes the wheel run. She puts together the entire team. So in March last year, we had a speech assistant, a second speech assistant join the team. And in June last year as well, we had an additional plastic surgeon join the team. So do we have challenges? Yes, we do. It's very difficult to have the entire team meet physically. I don't know if it's difficult for other teams, but it's very difficult to have this entire team come together. Though we normally manage to do it once a year because we have an in-house cleft camp. So during this cleft camp, we come together somehow as a team. But other than that, we usually communicate through the patient files and personal calls, like in calls and through the nurse coordinator. Next slide. So this is an outreach at Elwak, the northern part of Kenya, which is predominantly Muslim. So you'll notice we even have to wear, to respect the community, we have to dress the part and cover our hair. Next slide. 2024 PACT meeting, we sent in surgery, orthodontics, and speech. And what was the impact? Next slide. Next slide, please. We always come home challenged on how to gel our team. And the take-home message from the 2024 PACT was actually the surgical readiness form that Dr. Emily shared earlier, that actually has everyone comment on the patient before the patient is admitted or as you're making a treatment plan for the patient. So once the patient comes in, if you have the surgical readiness form, which we incorporated in our file, you'll have everyone, including the orthodontist, the nutritionist, the speech therapist, see the patient and actually comment what are their concerns for this patient, and is it okay for the patient to proceed with the next course of action. So for us, I really love that form. That was our take home, and we incorporated it. Yeah.
Dr. Nyama, you brought us right up to 2024, which is wonderful. I know that there are lots of folks who would love to jump in and ask some questions about the kind of journey that you're there. Is there one final slide you want to share with us, or I just want to make sure we're fulfilling our promise to everyone to be able to ask you some questions?
Okay, so this is the end. Actually, it just says we started uploading our speech cases. If you could show the last slide, Emily. It's on where we are as a team. Backwards. Sorry.
That one?
No, just move back.
This one?
Back? No. Yes, like, do we have things that we want to do? What are our next steps? Yes, we are not performing all the surgeries, and we want to be able to do cleft rhinoplasties, orthodontic surgeries, pharyngoplasties, and the surgeons are being taken for training early next year. Next slide. Yes, and we are still pursuing orthodontics funding, though we are starting anyway. So we will start uploading the orthodontics cases, and the funding will find us on the way. And finally, we want to include the ENT surgeon and audiologists in our treatment. So yeah, that's our plan.
Fantastic. Thank you, Dr. Nyamu. Thank you, Dr. Gallagher. So everyone, this is your chance to collect your thoughts. We've had both an overview from inception to 2024 about how this training program has evolved. So we want to think about that and what you found interesting or helpful, or what you'd like to clarify about that. We also saw a specific journey of the team in the area. And Dr. Nyama has brought us in a little bit from moving from that outreach or mission model into a year-round care, and how that's been going on. And even from the very end, hearing from Dr. Nyama about some of their hopes for the future as they continue to build out this team. So my question is, what stands out for you? We've had some discussion in the chats about from some experiences of that kind of high-income country, lower middle-income country partnerships, what worked well. But let's think a little bit more, and as always, spend some time in discussion. So feel free to raise your hand if you'd like to ask in person, which is great. If you're speaking in Spanish, then you're welcome to do that as well. Otherwise, you can feel free to use the chat. And so my question is, what stood out for you? As people are gathering their thoughts, one of the questions I had for either Dr. Emily is, you mentioned this, what started out as an in-person conference, as technology and everything else has improved, has now moved into in-person, but also regular touch points digitally. And what do you find has been the impact of that? And then what motivates people? I mean, sometimes people have a great experience in person, but what motivates people to continue that connection on the online format in between your in-person, which is something probably lots of us have experienced. Maybe we'll go for you, Dr. Gallagher, first, and then Dr. Nyamu next.
Sure. Well, I really think that nothing really compares to the in-person work. It's just so valuable to be together, to evaluate patients together, I think is truly the highlight. But I think that there's so many questions and concerns and things that come up aside from that 1 week that we're all together, that it's just a really nice touch point for people again. A lot of times I think the teams are so thoughtful about what they want to discuss with others, partly to show where they've come and what they've been working on, and things that they're proud of, but also as a way to ask questions of others. So I don't know, I think it's really been a huge asset, sort of a silver lining of COVID, really, to have that opportunity to connect through the digital platform.
Thank you. Dr. Nyamu, how about you as someone, have you engaged in some of the virtual extension of PACT, and why? What have you found helpful about that?
Yes, we do. Actually, we present as a team sometimes. And I think the in-person one is like, I feel, to me, PACT is almost like a family, because like the teams actually just share their what works for them, what doesn't, and there's so much ideas from everyone that you become friends. And so when we have the virtual meetings, it's just a meeting, like it's almost like a call with friends. So I think that in person is what makes the virtual meetings more successful, and you know, you actually want to attend and you want to share your experience with everyone. Yeah, and learn from everyone.
Very helpful. Again, please feel free to jump in the chat. I see a question from South Africa about specifically, you know, how is there an opening for other teams to join PACT? So, you know, what's the status of that? Obviously, people see something that's good that's happening. I don't know who wants to, which of you would like to address that?
I can take that one. I think that the PACT team leaders are the ones who are making decisions about when to admit another team. There is this idea that every few years the leaders would like to add an additional team, but it's something that has to be done with very thoughtfully, because we don't want PACT to become too large so that we can't all learn together. And yet there is this recognition that there are other teams that would like to participate. I think the PACT leaders tend to be so well connected among all the teams in Sub-Saharan Africa that they're also looking for, you know, what team might really benefit from participating. So I don't know exactly what the process is like for that, but I know that a lot of thought goes into doing it with the right balance.
Emily. Dr. Nyamu, for you, I mean, obviously there were, and I'll see Dr. Savitha next. Dr. Nyamu, for you, I mean, we have some very experienced cleft leaders at the very beginning of PACT, like Dr. Donkor or Dr. McConnon. And for you, you know, can you explain a little bit about what do you see as the value of having, you know, professionals from Seattle at the in-person conferences and online, as well as professionals from other countries in Africa? How would you distill that as that mix, and what's helpful about that for you in terms of PACT's composition?
I think for me, what stands out, like when I see, you know, like the leaders here, and then like best practice, say from Seattle, is that we are all aiming at the same thing, that care is standard, and really it should be at the same level wherever you are in the world. And yeah, it's a beauty to see what's best standards, but also to appreciate how far we've come as Africa, and to see the innovation, to see the drive. And like I did talk about Donkor and Professor McConnon as visionaries, because from where they started, there wasn't anything like this, and yet we've come this far. And right now, as we speak, we have comprehensive cleft care centers in Ghana, in Ethiopia, and soon in Kenya. So, and I bet in South Africa, maybe it's just that they haven't had a chance to share. So,
Lovely.
Yeah, so that care should be standardized wherever you are in the world. And really, this is what the aim of PACT, or even this webinar we are having right now, is.
Thank you, Dr. Emily. Savitha, your hand has been up. Please go ahead.
Yeah, thank you, Hugh. Amazing to listen to both the Emilys out here, and it's really impressive to see the kind of growth that they've had from where they were with just 2 professionals in the team to having a full-fledged team currently. Hats off to you all for that. And I really like this idea of multidisciplinary intensive training. My question to Nyamu is, when you have a professional other than a core speech professional go in for the training program, like how in your case you had a theater nurse who had gone in for the training. What kind of accommodations do you do for them when they come back after the training? Because I've seen in some places that, there's always this dilemma when somebody is by principle a professional in one particular category, and when they get trained in another discipline, how do they balance between the two when they come back? Like after the training, was this person a theater nurse predominantly, or was she a speech professional predominantly? And how did the hospital make adjustments to facilitate her to take on the speech professional role?
Oh, that's a very nice question, Savita. And actually, let me say we had challenges when she did come back because she was still expected to do her nursing duties. And we still wanted her to have speech therapy sessions with our patients. And for a long time, she actually would volunteer her free time, her off days. That's when she would book the cleft patients for their therapy. But then at some point, that's where I said, you realize you do have to have the hospital administration on board with you. And if you notice, one of the key members in the hospital admin was the hospital nurse manager. So once they realized how key she was in this vision for the cleft team, they actually moved her from theater. I think she was posted to the ward duties where she would have a bit more time to now do the speech therapy within her working schedule. And then later, the hospital actually allowed someone else to do speech therapy training, and now they are two. So between the two, they are able to share the work without it being out of hand or out of their official working hours. So yes, you must have the hospital admin involved. It was an issue.
So currently her professional role still involves both nursing as well as speech.
Yes, it does. But when she's not available, then the other person will pick it up, will pick the therapy.
Yeah, because most oftentimes that's where the challenge has been, the way they balance between the two, because it's not that there is surplus in the other professional as well. Nurses are in huge demand too. It's not like there is a surplus of nurses that you can take one off and just say, okay, take on the role of the speech therapist there. Yeah, very interesting to note. And thank you very much.
Thank you, Savita. Very helpful. And I'll do a quick plug. We are, as some of you know, the Circle of Cleft Professionals hosts a virtual conference every second year. And so that, Emily, was one of the topics, that sense of the essential advocacy, internal or external, that needs to happen as we move towards comprehensive cleft care. I'm just discussing with our administrator or the Ministry of Health about how roles are acknowledged, about how time is split. I mean, what is volunteer time and what is paid time? These are all some essential things. And I think comparing notes in every context can be so helpful for that sort of thing. So I'm really delighted that you've focused on that, Dr. Niamu. Other questions or comments? Yes, go ahead.
Hi, sorry, I don't seem to have my camera on, but hello, everybody. It's been a really very, very interesting session for me, being based in London, but having worked overseas. I'd like to ask about outcomes because, there's a tremendous improvement in delivery over the years. And I'm just wondering how and if you've been able to measure or at least to assess the impact of what you've done to, in fact, also to convince your administrators and the people who actually provide the finance and the encouragement for you. I wonder if you could give us a little bit of background on that.
Sure, and we've got 1 minute for the answer, so I'm not sure which one of you wants to jump in, but yeah, how do we know this is working?
Okay, if I may. One of my slides, which I didn't get to share, was about research. Like we've been having to recall our cleft palate patients so that the speech could actually upload all the cases. And we are actually doing research on what our speech outcomes are from our cleft palate cases. So this would be, you know, a paper that will be very helpful for us, because closing a palate is not just closing the palate. Actually, the success is the speech. Speech will tell. So yeah, so, and I do agree that when you work as a multidisciplinary team, actually the outcomes are way better than these outreach cases, because you have no form of follow-up.
Right.
Thank you, Dr. Nyamu. Thanks, Dr. Alex. And I think that is an interesting piece, is that in gathering in person and online, these partners for African Cleft Training, folks, there's a lot of folks with experience in research and setting these up. And so I think Dr. Emily Gallagher's slides also pointed to some innovations that came out of that, like Christine McKinney's Nifty Cup, et cetera, et cetera. So the sense of just even rubbing shoulders with folks who have that research experience in mind, I think is pushing us all towards these outcome measures that I think, Dr. Alex, thank you so much for raising that. The hour has flown by. We have a few more things to cover. I'm going to point it back with a huge thank you to Dr. Emily's, to Niti, for a couple of seconds of important information updates.
Yes. And also, I'm going to now share a really quick poll. This is a 3-question poll for feedback on our current webinar. It is completely anonymous. So here goes.
Demonstrating some data collection in real time here.
There you go. You have 40 seconds to fill this out.
It's a new thing we're trying. We're grateful if you participate.
Okay, thank you so much for joining in on the poll. I have some quick updates as Hugh shared. So how best to make the most of Circle, our top 5 tips. Watch our 4-minute navigation video, which will take you through everything that you need to know about Circle and its different features. So when you log on to Circle, you can go to the Start Here space, and right at the bottom, you'll see a video titled Navigation and FAQs. Once you log on, make sure you complete your profile and don't forget to add a photograph to your profile. We all have different needs on how much or how little notifications we would prefer. So once you've completed your profile, we highly recommend that you check out the notification settings and customize notifications as per your needs. So you can choose email, in-app, or mobile notifications for the different interactions that's available on Circle, and enable DMs. This is one of the best features for networking that the Circle has to offer. So highly recommend that as well. Again, download the Circle app on your phone. It's accessible on both Android and iOS. And last but not the least, spread the word, invite your colleagues to join Circle. All they need to do is apply to the COCP, which they can through our website, cleftcircle.org.
Great. And a few things, if you came in late, this is the new networking platform. It's totally free, sponsored by all the sponsors of the COCP. So if you'd like to learn more, then cleftcircle.org, that's the place to figure that out. And if you don't know the acronym DM, that stands for direct message. So a way of contacting people without having to know all their emails and how they move around. So that's up to you. Thanks, Niti.
Thank you. Yes, so if you haven't already, please follow us on our various social media platforms. And if you have any webinar suggestions, any queries, or else would like to share articles or other materials for Circle, please email us on info@cleftcircle.org.
Thank you. So a huge thank you to Dr. Nyamu and Dr. Gallagher for sharing with us this morning. Thank you for the nice interaction along the chat, as well as in real time as we talked about here. And I think the takeaway for today is thinking back again to where your team is at in its own development towards comprehensive cleft care. As Dr. Nyamu has mentioned, there is a thread that goes through everyone on this call of wanting the best for children affected by cleft lip and palate. And I think that mix of interaction among your team, among interaction in your region, but also how you're interacting with high-income country folks who maybe have a longer experience in this cleft care journey. That's also a key question that PACT is posing for us, and then how to make the most of the learning adventures that we have together. So I'm really grateful for that input today. If you do have further comments, we can continue that. If you do have Circle, that comes as a conversation that could be ongoing. And I do just want to acknowledge Adam has posted in the chat there, as well as a thank you, but that sense of moving his own journey from moving from nursing to speech language pathology. And if you are interested, there's a podcast dropping this week that talks about that journey. So I won't say any more about that, but that's coming. Thank you to everyone. We start on time, we end on time. The end of the hour is here. We're grateful for you carving out some time for learning and networking together. And a big thanks to everyone. We'll see you next time. Bye.
Everyone.